Hi, my name is Rakaya. I'm an Omani doctor currently working in surgery here in the UK. I genuinely love what I do, and outside of work, I also enjoy filming, storytelling, and editing videos, which is how this channel started. Here you'll find glimpses of my life as a surgeon, from clinic to operating theatres to on calls, studying, traveling, and basically everything in between. So, whether you're curious about medicine, surgery, or just enjoy a behind the scenes look at hospital life, I'm glad you're here. Welcome to my channel. Hi, good morning. So, the aim of the video this week is that I wanted to try and capture what a typical work week looks like. This week is a very good one to try and capture because I've got a variety of shifts. I basically have a mix of elective theatre days, I have clinic, I have a trauma, mortality and morbidity meeting as well as an audit meeting, and I have a 24-hour on call right in the middle of it. And I thought it's a very good one to try and capture. So this week, the schedule is basically like this, assuming that it doesn't change because it can change last minute if there is any sick leave from my colleagues or any additional cover needed. What I have at the moment, today is Monday, so today I'm going to our elective operation center. This is different from the hospital that you usually see because we do all of our elective operations in a different hospital. So today's Monday. I have 8 to 5 theatre, elective theatre. Tuesday I will have again 8 to 5 elective theatre, same place. But the addition would be that I'm also holding the emergency bleep. So if there's any emergencies, I have to answer them while also having the 8 to 5 operation list. Then on Wednesday, I have a morning clinic.
We are now approaching. Please mind the gap when alighting from this train.
So on Wednesday, I have a morning clinic followed by an afternoon mortality and morbidity meeting as well as an audit meeting. They happen in one setting. So that basically means that on Wednesday, I'm the emergency cover overnight. And as you probably would have seen if you've watched my previous video about the 48-hour on-call, you've seen the structure of it with the 5 p.m. meeting, 5 to 9 standby, and then hopefully going home and praying that I don't have to come overnight. On Thursday, which is basically the continuation from the on-call, 8 o'clock morning meeting, then 8 o'clock morning meeting followed by the ward round with the consultant, and hopefully if things are going well, I'm going home at 10. Friday I have a double clinic, and these are all the trauma patients that basically had to be seen, all the new injuries. Saturday, Sunday, thankfully I'm off because I'm not doing any 48-hour on-calls anytime soon. So I'll try my best to try and share as much I can about this week, and I hope you all enjoy it. The one thing I love about this journey to the elective hospital is that honestly the views are amazing, and it just shows you how beautiful Scotland can be. And I'll try my best to try and film like some of these scenes for you guys. Alright, just wanted to show you guys the view that I see every time I come here, and I think this is one of my favorite views ever. That is just beautiful. Behind that house, there's actually a very big lake. And the patients inside the hospital actually look at a similar view. And I think it's just amazing. And it probably helps with the recovery. I mean, if you're looking at something gorgeous like that, after you reach and you're done with the train, it's a bit of an uphill bit of an uphill walk to the hospital. I think it takes about 10 minutes uphill and take a lift to get to the ward. What I'm going to do once I reach the ward is basically make sure that the patients are consented. Now, these are elective patients. That means they were consented before. We do have a consenting clinic. And because, all right, not as fit as I thought I was. Yeah, so these patients were previously consented. So I basically have to just go double check that the consent is fine and the patient actually wants to continue with the operation. Just copying today's list. Can't show it to you. I'm done.
Especially like with in August. Say it? Meth. There's chatting with some of the nurses.
All right, just collecting the bleep. Because I am both theater and bleep holder today. Going back upstairs. Please don't ring today. Please don't ring today. Please don't ring today.
No, I'll come. It's the pre-op pills.
That's what I was thinking, 'cause I know that they...
Yeah, no, they can play.
Did you put the chain in the field, like, I would say it's the field body, like,
Unfortunately, the bleep did ring. There are 2 patients to be reviewed. Just one floor below me. We've just finished the brief for the 3 patients that we're going to do the surgeries on. So I'm just rushing downstairs to see these 2 patients. So while I'm reviewing these patients, they are also getting our surgery patient in order to be anesthetized. So I'll try to make sure that my review of these 2 patients is thorough, but at the same time concise, in order to make sure that I'm not delaying the operation.
positive. You want that too?
Hello. So basically finished the list for today. We had basically 3 operations, but they were 3 major operations. Well, the first one was a major one. The other 2 were semi-major. I don't know whether you can hear me or not, but I will try and I'll check it later. Now the issue is basically having the bleep, because while we were operating, I had a few patients that I had to go review. They were semi-urgent, so they just had to be reviewed on the same day. But the issue is one of them had a fairly significant infection that we basically call a necrotizing fasciitis. And this is basically flesh-eating bacteria. Quick pause, let me explain. What do I mean by necrotizing fasciitis? Now you may have heard of it. It's called flesh-eating bacteria or a flesh-eating infection. It's an aggressive infection that spreads through your tissues underneath the skin. And as the infection spreads, it can very easily destroy the tissues around it, and it releases toxins into the bloodstream. This can cause many patients to become severely unwell very quickly, and sometimes can lead to sepsis and organ failure. Patients may develop redness, swelling, blisters, they have a fever, or sometimes they just simply don't feel well. Now, one of the things we monitor very closely is the extent of the infection. Sometimes we will mark the edge of the redness with a pen and monitor it over time. When we come back to review the patient, not too long afterwards, we may find that the redness has already spread beyond that mark. And seeing that progression in real time is a major reminder of just how aggressive that condition can be. The scary part is how quickly it can progress. Someone can go from feeling unwell to becoming critically ill in a very short period of time. And that's why when we suspect it, we treat it as a surgical emergency and act very fast. The main treatment is urgent surgery to remove the infected tissue alongside powerful antibiotics, and they usually require intensive supportive care. And I had to very quickly evaluate this person, check whether they're stable enough to be sent to our trauma center, and arrange the transport, as in arrange the entire transfer. So in between my cases, having to review a case like this, that was super stressful, which is why I basically wasn't filming anything, because that was a very stressful situation and I needed to ensure that the patient basically was transferred to the other hospital quickly, because they needed to be urgently taken to the operation room. Anyway, pretty happy that the day is done. Tomorrow I'm not coming to this hospital, I'm going to a regular one. I have a, what do I have? I have a morning clinic. Tomorrow's Wednesday. I have a morning clinic. Afternoon, we have our mortality, morbidity, and audit meeting. I'm also on call, which means I'm on duty for 24 hours. And I'm sure, as I've explained it before in a previous video, the 48-hour on-call video. If you haven't watched it yet, I've got the link in the description, so you can watch it there, where I basically explain the structure of the on-call. I'm exhausted. It's Tuesday, but it feels like it should be Thursday. This is a heavy week for some reason. But, that's how it is sometimes. Some of your weeks are just heavy and long, and this is one of the weeks that are just dragging, because I just feel like I need the weekend. But the thing is, we just finished the weekend, so it's okay. My clinic for tomorrow, thankfully, I already prepped it, and I don't have to prep anything for the mortality morbidity meeting, because I'm not presenting for once. I'm actually just a listener, which is a very good thing, because it's nice to just pay attention. I presented in the last 2, so I'm very happy that I'm just listening to this one. So yeah, I am just on my way home, getting the train, and then going to have some dinner, rest a bit, and then just prepare for my shift tomorrow and my on-call. I'll try to speak to you on the train, depending on how the train is. See ya.
There's so much stuff I wish I'd saved that I never was so annoying.
Hello, it is 10:40. Just got called overnight for an emergency. I'm 24 hours on call. Just got called for an overnight emergency. Well, there are 2 overnight emergencies, so we'll see what's going on. One of them is significant. Well, both of them will need to go to operation theater overnight, but one of them is significantly concerning because it's possibly flesh-eating bacteria. I just need to have to go and check it out. Hi. So just got called in for an emergency. It's now 11 p.m. I'm doing a 24-hour on call, and today is Wednesday, midway throughout the week. As I mentioned before, I'm doing a 24-hour on call. Initially got called in for 1 case, but it seems like we have 3 cases that need an urgent review. I managed to see one of them. He is marked and consented for an operation, but at the moment we are going to hold off and monitor him for about an hour or 2 just to make sure whether he's doing okay or not, and whether we do actually need to take him for the second patient is currently in the high dependency unit. Unfortunately, he's quite septic. He's really unwell, and this is someone who we're going to have to possibly take overnight. The main issue is that he's very unstable in a way that it's going to be very difficult to anesthetize him. So they're trying to stabilize him at the moment to make sure that we can operate on him. I had to call the consultant overnight as well, who is unfortunately having to come in because we do have these operations to do. We also have a third patient who is coming from another remote hospital that I'm waiting for to arrive to decide whether they do need to go for overnight operating. From listening to the history, it seems that there is a high possibility that we also need to take them. So I'm looking at 2 patients possibly for theater, and depending on how the first patient is doing after we give him the IV antibiotics, we might be doing 3. This yeah, it's looking like it's going to be a bit of a long night. And I had a feeling about this. The whole day was dragging for me. I had clinic in the morning and then the mortality morbidity meeting in the afternoon. And the entire day I had this nagging feeling, like this very mild anxiety that just wouldn't leave me alone. And it's like I had a feeling that I was going to come back to the hospital. The thing is, I left the hospital at about 6:30, reached home about 7:30, and then now I'm coming back to the hospital at 9:30, so I only managed about 2 hours at home. Oh well, it all ends eventually, right? Whether I end up going home overnight tonight, I'm not entirely sure. There's a huge what's the word? I'm so tired. There's a huge chance, there's a huge chance that I'm going to stay in the whole night until tomorrow, so we'll see.
No.